This program is brought to you by Grand Valley State University.
I think I'm this morning going to probably reinforce a lot of what we already know and have begun to hear. But from Spectrum Health's perspective, we are in the industry what's referred to as an integrated healthcare system. And I affectionately refer to it as having all parts or all three legs of the American healthcare system, where we have hospitals. We have 7 hospitals located predominantly here in West Michigan. We have a health plan with over 500,000 members, Priority Health, being here in the West Michigan area as well, but their coverage is across the state. And then we have our Spectrum Health medical group with a number of physicians now as well. So we really see the challenges that we face from the broad spectrum of the healthcare system, hence the name. As a result, in the fall of 2008, anticipating obviously a change in administration, whether it was the McCain administration or the Obama administration, we knew that healthcare reform would rise to the top of the domestic agenda. So we really were very intentional about taking our perspective and trying to develop what we now affectionately refer to as our principles on healthcare reform. And we put together a little booklet that really summarized our view of those all three angles, boiling it down into 4 key parts: ensuring health insurance coverage for all. We as a society can no longer really allow individuals to go without health insurance, either by choice or because of circumstances. Reforming our healthcare payment system, very critical, and that's what I'm going to focus on my opening comments, and certainly look forward to the discussion. Increasing access to quality and cost information. As consumers, we have very little understanding of what we're getting for the services that we seek. And then lastly, achieving effective and efficient healthcare services. Healthcare in the United States is really unique in that the way we are paid as an organization is very different from any other facet of the economy. We know that when we go into a restaurant, we eat the food, we pay the bill, and we leave. We know if we go to a grocery store, we buy the food, collect the food, pay for it, and leave. In healthcare, we walk in, you have a card, you maybe have a copay that's relatively modest, and certainly arguably has been going up over the number of years, but the larger bulk of the cost is paid by somebody else. So as a result, we as Americans really are separated from the consumer point of view from what the cost of the services are that we actually are receiving. Now, for the majority of us, we receive our health insurance through our employers. As the statistics were shown earlier, roughly 60% of Americans receive their health insurance from their employer. But let me explain kind of the business model, if you will, of Spectrum Health as an organization. And this is very typical of many healthcare providers across the country. In our fiscal year 2009, we had roughly 33% of our revenues came from the federal government in the form of Medicare payments. Another 18% came from the state government, which through the Medicaid program, and as many of you know, it's a federal and state type match. So those two combined, 51% of all of our revenues as an organization came from the state and federal government. So they're already a very large, significant contributor and impactor to what we face. Then 46% is what we refer to as commercial insurance. That would be Blue Cross Blue Shield, Priority Health, Aetna, Humana, and other insurance coverage, predominantly, again, the insurance provided by your employer. And then 3% is self-pay. These are individuals that come to our organization with no insurance, either by choice. They're the invincibles that never think they'll need it, or they're individuals of financial means and would view insurance as a waste. They'll just buy their health services out of pocket when they need it, or simply individuals who would like to have insurance, but because of life circumstances don't qualify for Medicaid, Medicare, and don't have it offered by their employer. The bulk of the bill that we have been watching develop over the last year really was focused on the 3% 3%. The individuals who have no insurance. And I don't mean to diminish the challenges that represents, but as we look at our organization and certainly the financial pressures that we experience, that's not where our Achilles heel is. Spectrum Health in calendar year 2008 incurred, or I should say provided, $119 million worth of services for which we were not paid. $119 million. But if you break that down, 84 million of it, or 70% of it, was due to the lack of payments through the Medicaid and Medicare program. So I would argue that the government is the largest challenge financially, in that they're sending thousands of people across the country, millions of people across the country, to healthcare providers, and then simply not reimbursing the providers appropriately to cover their costs. And I share that as well in the context of Spectrum Health as an organization is in the bottom quartile of costs when compared to similar sized organizations across the country. So we've already demonstrated, and although there's always room for improvement and we're continuing to do that, we've already demonstrated that we can maintain costs aggressively under what is the norm across the country for similar sized organizations, and all the while we're still not able to cover our costs through the Medicaid and Medicare. What this results in is what's called a cost shift, or a hidden tax, where one payer, that being the business community and those of us who buy insurance, picks up the tab for those individuals who aren't paying us, Medicaid, Medicare, and then of course the purely uninsured who have no means. Families USA estimated that to be roughly $1,000 per family a year of the hidden tax cost shift, or $368 for the individual. Now arguably, again, because the majority of us receive our insurance through our employer, the bulk of that cost is picked up through the insurance that our employers provide us. I would be of the opinion that we came dangerously close to passing a reform bill that would have truly changed the paradigm here in the United States. Healthcare, the healthcare reform bill, although it had many different parts, as Marianne was suggesting, and certainly covering various aspects of it, the employer mandate alone, I think, would dramatically change the situation. And we can talk about that in a little bit. But the public plan, again, was something that was very concerning to many healthcare providers, given the history of payment coming from Medicaid and Medicare, because the government has not been very accommodating to the cost. To give the government now even greater say in what they're going to pay through a public plan would very much create some financial strains on many healthcare providers. The bill expanded Medicaid. Again, it's 70 cents on the dollar is what it pays of the cost, and they were expanding it from 120% of the federal poverty limit up to 150% of the federal poverty limit. So let's put more people into a program that's already underfunded. And then, of course, with aging baby boomers, Medicare is going to see an explosion as well. Sorry for the baby boomers I'm sitting on the panel with, but
so Mark, can we?
I'll just stop right there.
That's great. Thank you. All right, Vondi.
I'm supposed to talk about the uninsured, but perhaps I should talk about back surgeries, and if any of you are interested, since I'm from Muskegon, you can probably arrange a nice back surgery for you. I come at this in a very different way, and a lot of it is based on my history, and I do run the health project, but one of the things you also need to know is I'm the director of community benefit for Mercy Health Partners in Muskegon, and part of my job also then is related to work that we're doing with Trinity Health in terms of looking at this issue of access to care and how we indeed can find some kind of a way to deal with the uninsurance problem in this country. We've spent a lot of time in the last 2 days talking about, pots of money, it seems to me, that move back and forth, and our impression of that, and also how we deal with it in an increasingly partisan atmosphere in terms of how we address these problems. I'd love to have both Pelosi and Boehner come to my office and spend a few days working with people who come to my door. And at risk of sounding, sort of bleeding heart here, I have to say that the environment that I entered into 15 years ago in terms of dealing with the uninsured has changed dramatically, obviously in the last 2 years, and because of the place I sit, which is Michigan, and more specifically Muskegon. Back when Clinton tried to address health reform, at that point I was working for a United States Senator, and we were dealing with numbers which were something like 32 million people across the United States, and we were going to try to get that job done, and of course it failed. I had, at that point, sort of moved back to Muskegon and had an opportunity that was, in retrospect, a very unique opportunity in that we were approached by the Kellogg Foundation, who looked at what had happened with regard to national health reform, and they said, we want to test a model. We're going to test it in Muskegon, St. Clair County, and also in Calhoun County, and we are basically going to give you money and ask you to do health reform locally. We're going to ask you to address the issues that nationally policymakers were unable to get their arms around and really provide some solutions. I thought that would be cool because I had worked in public policy, and gee, let's see where that goes. And years later, I'm still there, and the grant is long gone, but the work continues. We were asked to look at the things that all of us are continuing to confront today. How do you deal with the problem of uninsurance, and could you expand people's ability to access a coverage product? We did that in Muskegon with the development of a little product called Access Health. Access Health is a subsidized, community-run health coverage product. And while people may look at it and say, well, gosh, you're in Muskegon, I will tell you now there are 6 states that are participating in the SHAP grant process, which is it's a national grant that's available to states to begin to build infrastructure in their states for health coverage expansion, that including Access Health, which includes the state of Oregon, Colorado, Minnesota, Texas, where places like Houston and Dallas, those sorts of places are looking at it, New York, and I think also Virginia. One of the things that's proven to me is that communities actually have power in this effort, and Access Health, after 10 years, continues to provide a strong health coverage product to the people in our community at $150 a month, which is split 3 ways. One of the difficulties I had with health reform, frankly, was that nobody took the time to take a look at what those of us in communities had been doing to try to address the issue in the intervening years between Clinton and then what Obama decided to do. So we created our own coverage option in Muskegon. We looked at access. You've looked at access here. We've all done it. We've all embraced federally qualified health centers, so we've created primary care centers. We've created the ability to put people into primary care, but moving them off into specialty care remains a challenge, and as a result, those who are very sick end up, of course, just aggregating even more costs to the system. We were asked to look at using data, health data from our communities, and we jumped into that very readily, only to find that over time, as the economy has floundered in Michigan, that our ability to get our hands around public health data and the assistance of our public health department has become even more and more strained because we just don't put those investments there anymore. And we were asked to talk about healthcare resources, and since I work for a health system now, it's a little different to talk about this, but at the point at which we were doing our work in Muskegon, we had 3 hospitals. They were later consolidated into 2, and I've been surprised that in none of the discussion I've heard in the last 2 days, no one's talked about this issue of competition between hospitals. And I work for a system, they compete, the competition in and of itself, we compete for those people who can pay, and then we have to deal with these people who cannot pay, and then what that does to our bottom line. And of course, later we're going to talk about costs. One of the things I have learned, having had this ability to travel, and I've worked in probably 45 of the 50 states. I've had that opportunity because we did something right in Muskegon. And so I've been able to go to a lot of places. And I went to New Orleans prior to Katrina. I got a look at Charity Hospital. I heard people tell me about how they waited in line for 18 hours in an ER. I thought that was nuts until I talked to the director of Charity Hospital in the Capitol, who said, yeah, that sounds about right. people bring their lunch or their dinner if they know they're going to the ER because they're not going to sit there. What struck me about that as I thought about Michigan and would return here was my thought that, you know, I've like many people who didn't come out of a healthcare background, my assumptions were that Medicaid and programs were kind of universal wherever you went in the United States. They are not. And we are darn lucky to be in Michigan. I appreciate your comments about the strong history that we've had here in terms of insuring people, in terms of looking at the benefit of having a workforce that is strong and healthy and what that means to an economic driver. I went to UTMB, University of Texas Medical Branch, Galveston, where they're the only provider on that island, where they have one clinic, and where they talked about the fact that the majority of people they were seeing were homeless. They could not control those costs, and they finally got to a point where if you were uninsured and you came to them for help, that there were certain types of cancer drugs they were no longer going to give you because they couldn't afford to give them to you. We talk all the time about, well, we're not pulling back health care. Indeed, we've pulled back health care. We've pulled back assets from people in parts of this country. We've been doing it for a long time. At some point, that begins to roll north from the South, with all due respect to the South. I'm a firm believer that, you know, it's at some point all of that rolls over into all of us, that the uninsured people that we meet every day who are fixing our coffee at the Starbucks or some other place, at some point when they get sick, they will roll into my ER at Mercy, and those costs are going to roll up into my coverage product. So this belief that somehow we can segregate one another and not deal with this as a country is ridiculous. If we decide we're going to go in that direction, and that indeed our partisan differences are such that we can't sit down and talk about it, then it falls upon all of you as community members to begin to figure out what are the next steps and how do we do it. I'm here from Muskegon to help you, to tell you you can do that. But I will also tell you, at the point at which we began to create Access Health and to do that, we were dealing with somewhere between 9 and 11% on insurance rate in Muskegon County. Today it's at 24%. In Oceana, north of us, it's 27%. We've blown past our resources, and that creates structural pressure upon the work that we do, not just in terms of the safety net services, but the hospitals that are there to serve all of us. I suggest to you that it's time for this country to sit up, take notice, and to decide this, and the partisanship needs to be put aside. At some point, adults in a political system need to sit down, talk to one another, and figure this out.
Dennis, thank you.
I should just pass and second Vondie's motion there, probably. This is the third panel I've been asked to speak on that was scheduled to take place 1 week after health care reform was implemented. I'm beginning to think maybe it's me. But from a standpoint of not what did we get, what would we get? I think what we would get that was worth fighting for is something closer to universal coverage. And this really seconds Vondie's comments. As a country, we need to step up and face an issue that every other developed nation has faced, that the government has some responsibility to provide some safeguard to its citizens with regard to health care. What we, as a country, are squabbling over and haven't come to agree on is how much of that responsibility falls on insurance. And given the fact that we, particularly in Michigan, have had very generous benefit packages, nobody likes any discussion about the fact that how much of this responsibility should come back to the individual, how much of this responsibility economically for your insurance, but more importantly, and I'm not hearing any discussion on this point, how much responsibility for your health care remains in your hands as opposed to the hands of the healthcare delivery system. So two things that I think we were on the verge of doing right, and I'm hopeful that we will be able to drive that last foot and get it over the goal line, is something closer to universal coverage. And had the House or Senate package passed, we would have been at about 95% universal coverage, coupled with insurance reforms that would prohibit insurance companies from walking away from people with pre-existing conditions. I think those were probably the major social accomplishments that would have been accomplished had reform passed. But equally important, more important in my humble opinion, is what we didn't do. We have a healthcare system that is unsustainable. It economically cannot sustain itself, and it is going hell-bent for leather in the wrong direction with regard to sustainability. We have to address the issue of sustainability. And the proposals that were both in the House and in the Senate didn't create any legislative fixes. To be fair, it is not possible to create a legislative fix to fix our healthcare delivery system. We're going to have to do that from the inside. Marianne referred to an author, Atul Gawande, who's got a lot of popular coverage lately for his views on healthcare. And he pointed out that you can fix insurance regulation with statute, you can fix coverage with statute, but you really can't fix the healthcare system with statute. The healthcare system he compared it more like the agricultural industry of the 1900s. You can't fix it by statute. We had to create the cooperative extension service and gradually create an awareness among the farming community that there is a better way to do things, there's a more efficient way to do things, and gradually the farming community did come together and really did that major transformation in the early 1920s. And that's, I think, what we're faced with in healthcare. So what we did, what we almost got, better coverage and insurance reform. What we didn't get, any kind of change to our healthcare delivery system that was going to bend the cost curve, in the words of President Obama. Ladies and gentlemen, bending the cost curve is not an option. It is absolutely necessary. And my colleague referring to my people, the boomers, power to the boomers.
Yes.
I see some of my people are here. We'll have a burning of something later to celebrate our boomerness.
Go there.
Well, yeah. You're giving away your age.
I know.
Boomers in 2011 start turning 65, and there's nothing magic about 65, but as we all know, older populations use more health care, and there is a big cohort of boomers. That is going to drive up the need for health care. It's going to drive up the need for health care at a time when our health care infrastructure is particularly fragile. We are going to have to make changes, and if I had more than 5 minutes, I'd tell you what they were, but maybe the next panel I'll get back to talking about what they were. One more thing that we got that nobody is talking about, and we already got it to some extent, was promotion of healthcare information technology. This is a major step forward in healthcare in terms of understanding patients' healthcare behaviors, what providers are seeing, what medications they're on, cutting down medical errors, improving the quality of care. And the healthcare IT promotion dollars was not in the healthcare reform package, it was in the stimulus package, the ARRA package. So that passed, and that money is beginning to trickle out into the field. So I would add that into the one thing we actually did get thus far is some money to promote healthcare IT, which I think will move healthcare forward substantially. But that also is a 5 to 10 year game. So I'm going to assume my 5 minutes is up because I'm getting dirty looks at Marianne. Thank you very much.
Just moving the floor. Thank you.
I'm going to do something a little unorthodox here, and my apologies to the cameraman. I'm going to go to the audience for just 1 second. I want to hand something out.
I think he's running for office.
I'm running for office. One of these, and there's a sentence on each one of these. You can just take one out, pass it around.
He has these new novel teaching techniques about audience participation.
What is this meeting for? It's healthcare reform or something.
also have one visual, if I could make it work here. Oh, thank you. Give your speech. Thank you. Well, you can either thank Mandy for not allowing me to have any slides. So I did a couple of things there, but I know some of you still may be looking at that sentence, but we'll get to that in 1 second. But I think, what I was thinking about, what do we get out of healthcare reform? And, obviously that question is still unanswered. But I think, too, I think with the panel, in many ways, I'm glad to see the current bill's demise, even though I am really for health insurance reform and believe that we need it. But I think what I would like you to take away from what I have to talk about this morning is that I think I would, warn both politicians and anybody that, health insurance is not the panacea that we think it may be. So, in that respect, each one of you has a piece of paper on it, or maybe most of you do now, and there's a sentence on it. And so each one of those is a different sentence. So if you could do one thing for me really quickly and count the number of F's in that sentence. So how many of you have one F in your sentence? How many of you have two F's in your sentence? Okay. How many of you have three F's in your sentence? 4 F's? 5 F's? How about 6 F's? Okay, here's the trick I just played on you. You all have the same sentence. There's 6 F's in that sentence. So why is that? So it's because you can't see, you're reading everyone that's of, right? You read as a V. So your brain doesn't count it, right? So if you go back, it's probably all the ofs that you missed. So my point here is that we need to think about paradigm shifts. So again, you're probably scratching your head here for a moment. So just hold that thought, and I'll get to that. So, and if you were here last night, a number of the panelists too had talked about some of their favorite books, and I too have read The Healing of America, and by T.R. Reid, and it's a good book, and I've been using it for my class, and I wanted to read you a couple of things from it. It says, at the beginning of the 21st century, the USA is the most powerful, most innovative, and richest nation on the planet has ever known. But while this great nation is strong, smart, and wealthy, it is not particularly healthy when compared to other developed nations. When it comes to the essential task of providing health care for people, the mighty USA is a fourth-rate power. So when the WHO rated the national health care of 191 countries in terms of fairness, the U.S. ranked 54th, ahead of Chad and Rwanda, but behind Bangladesh and the Maldives. So overall, France is number 1, as you may remember from last night. Costa Rica is 36. USA is 37, and we're ahead of Slovenia, which is 38.
All right.
So, and the interesting thing too is that I've been to Costa Rica twice now, and it is a wonderful place. And I would say, put it on your list of things to do this lifetime if you haven't been. But the question I ask my students often is, if you were in a car accident, if you needed to go to the emergency room, if you needed care, if your mother needed care, if your father needed care, would you rather be in Costa Rica or would you rather be in the United States? Where would you rather be? Where? France. United States. France. So France, but...
Depends on the state.
But right, it depends. It depends. And, I think universally most people say the United States. And I find that interesting. So that was, sort of what, made me think I need to dig into this question a little deeper. So, one of the things that I did was I looked into, how the WHO came up with these rankings. So, and one of the things is, and again, I don't discount that our healthcare has problems, but I didn't realize how subjective the scale was. So the WHO ratings is based in part on what the WHO believes that we could have done better. So because we do not have universal coverage. So what apparently does not matter is that our population has universal access. This was from a recent editorial in the Wall Street Journal. Because most physicians treat indigent patients without charge, except Medicare and Medicaid payments, which do not even cover the overhead costs, which I think is what our colleague from Spectrum was saying. So, but what the WHO does rank is U.S. number one of 191 countries in responsiveness to the needs and choices of the individual patient. So I think that's kind of an interesting thing. So, out of 23 wealthy countries, the American healthcare system ranks dead last when it comes to keeping our newborns alive. So our rate of infant mortality is more than twice as high as the rate of top-ranked countries, Sweden and Japan. So, and again, I'll draw your attention to my visual aid over here to the left. And I know it may be difficult to see, but those are three maps of Grand Rapids. So, and what got me interested in that, again, I'm one of those old faceless Medicaid bureaucrats from Texas, and I've always had a real interest in Medicaid. And the thing that I started noticing was that, I was looking at a study that I was doing with an undergraduate student of mine, Andy Wilson, and we looked at the percentage, or we looked at the providers who were accepting Medicaid. So we looked at, and this was again a couple years ago, it may be different now, but we looked at Priority Health, for example. So if you're a Medicaid patient, if you're a mother, a pregnant mother at Priority Health, I think there were 10 or 15 or 20 OBGYNs in the Priority Health system, but only one accepting new patients. One accepting new patients. So, that's a real problem, right? It's an access problem. Again, and I think that's an interesting thing. And again, I would read you a quote from this book. A key reason of what T.R. Reid says, the reason why our infant mortality is so high is that your rich countries offer free prenatal and neonatal care to every mother and every baby. And so again, I asked my class, and I would ask you, everyone in this room, this same question: do we not offer free prenatal care to every pregnant mother in this country? Maybe not universally, but pretty close, right? Virtually any pregnant mother can qualify, low income can qualify for Medicaid. And what is not, and a pregnancy is one of the few pre-existing conditions that insurance cannot exclude you for, even in Michigan, even in Texas, if you can believe that. So, what I would draw your attention to is that what Gustavo and I did, who works at the Center for Community Research Institute, the Johnson Center, was that we mapped all the births here in Grand Rapids. And again, I know it may be difficult to see in the back, but one thing I would say, keep your eye on the middle. And what do you see there? Green is good, red is bad. So the first map on the left is the percentage of mothers with a high school degree. The middle map is Medicaid as the primary source of payment. And the map on the right are mothers receiving inadequate prenatal care. So if everyone has access to health insurance, then why do we have so many people having inadequate prenatal care? So I think that's an interesting question. And again, a lot of the health reform topics that we have were about expanding Medicaid. Of course, we've seen Medicaid cuts this year. So we've heard that Medicaid doesn't even cover the cost of overhead. So again, I would say that we need to think about other things just in regard to health insurance. We can't pat ourselves on the back if we get a bill passed and say all is well because we have universal health coverage, because we still see that these disparities exist no matter what, right? And I think they will continue to exist, and it may even get worse if we don't invest the money, the requisite money to ensure that people do have appropriate access. And again, that access is much more complicated than just a function of health insurance. So.
Thank you. David, thank you.
Thank you. Very pleased to be with you this morning, and want to answer a related question, which is, what should our healthcare system reform look like? And what I want to suggest is that there are substantial problems with the design that we have, and offer a model that I think is out there for much improvement around a different design. Marianne suggested that physicians are pretty traditional when it comes to stepping up to addressing this issue of change in healthcare. And I want to suggest to you that as a leader in Advantage Health, that we are vigorously trying to change our delivery system. We are holding our physicians accountable for performance on a variety of chronic disease and preventive measures. We're working tightly with specialists to integrate care. Change cannot come fast enough. We think the nation needs it desperately, and we are applying ourselves to try to help direct that change as much as we can. I would suggest to you that one of the most critical things that we lack, and it's impeding our ability to move forward with change, is a vision for where we need to go with change. And I want to suggest to you some ideas around that. The Institute for Healthcare Improvement is one of the leading organizations that is building that vision for a better healthcare system. Don Berwick is the leader of that organization, and they've suggested something for the nation, that we pursue something called the triple aim. It has 3 goals, that triple aim. First is to improve population health. The second is to reduce per capita cost. And the third is to improve the patient experience. Outcomes, that means clinical outcomes, safety outcomes, and satisfaction or service outcomes. So a triple aim of improving the population health, reducing cost, and improving the patient experience. That actually is not how our current system is structured. We have very little that really our organization that actually is financing to drive forward and do things that would improve population health. We have a payment system that actually pays just to do things to people, but those tend to be quite late. A recent article in the New England Journal of Medicine, December 10th, is an excellent summary of some things that are critical to change. It's entitled Primary Care and Accountable Care, 2 Essential Elements of Delivery System Reform. It's probably worth looking up. If somebody wants the reference afterwards, I have it. It's only 3 pages, so it's easy to read and get the basic ideas of it. It's built around the notion that 2 elements that are beginning to grow in the country really form a backbone for how we can have improved reform. One is something called a patient-centered medical home, and the other is an accountable care organization. And the notion is that you link these 2 together, and you have a remarkably different model than what has sort of been referred to as that cottage industry model of U.S. healthcare. The patient-centered medical home is sort of a reinvention of primary care. And all the primary care academies in the country got together in 2007 with some major industries and issued a set of joint principles of the patient-centered medical home. They basically are basically these. They say that every American should have a primary care physician. That primary care physician should be the leader of a healthcare team, that team made up of RNs, PAs, registered dietitians, and like. That care should be comprehensive, that they should be dealing with all the medical issues that come to people. That care should be longitudinal. That means it goes out over years, decades, a lifetime. I started here in 1979 as a resident at St. Mary's in Family Medicine, and I now have a few patients that I have actually seen for 30 years. So you build that longitudinal relationship. The care needs to be coordinated, so it means that you're working tightly with the specialist when you send the patients to them, and you have developed mutual expectations. You're also working in a coordinated way with community resources. The care is in a model that is highly relationship-oriented. You know the person, you develop a trust back and forth. That the model really works to address access. The people need same-day access so that they're not in emergency rooms because they couldn't get into their office that day. That their offices start early, that there's somebody available with later hours. You need to have teams to do this because you can't work around the clock. But there are ways to build these kind of schedules, that the offices actually have weekend capabilities, so people share between offices to create options for people. When you get the patients into their primary care offices on a weekend, it's less likely that they're going to get high-tech workups. And finally, this thing have a model of, or be built on a foundation of an electronic health record. That record can manage patient data, the experience. It will interface with the registries. You build these registries. What we're doing, we have registries on many disease states now in Advantage Health. We know our 8,000 diabetics. We know their blood sugar, their blood pressure, etc. For every physician, every patient, and we're reaching out to those that have gaps in care to pull them in and improve that care. That you begin to build care plans for people, so when people leave, they have that information about what's important in their hand. And I regret to say that most of you probably have never received a care plan. Hopefully you will start to receive that from your physicians in the next year or two. We perform e-prescribing, so we're interfacing with your insurance plan, your benefit model, and prescribing the covered prescriptions. And finally, that you have portal functionality out of the electronic record that would facilitate moving information to patients and to specialists. So those are some basic elements of that patient-centered medical home. The Accountable Care Organization is a new version of describing what in the past was referred to as an integrated delivery system. The Accountable Care Organization can be thought of in different layers. The first layer is a primary care system that really is becoming tightly integrated around these expectations. A level 2 Accountable Care Organization is a primary care linked tightly with specialists cooperating in patient care. A level 3 begins to pull the hospital in to this, and lots of places have primary care specialists in hospitals, but that doesn't mean they plan together. They may be in quite random, the ways in which they relate to each other. They're all little fragments, they all have their own business models, they all have their own focus of a solution to the needs of the patient. What we need is to integrate this, people plan together, and you can get far better toward outcomes. And finally, that a level 4 accountable healthcare organization would begin to involve the community in this integrated experience. And so that accountable care system would actually work to optimize care. It would work toward outcomes, integration. It would work to optimize the service experience and optimize the financial performance of the system. So I'd suggest to you that we need a vision for our healthcare reform. We can build it around a triple aim, and that we begin to look at how invigorated primary care, which Barbara Starfield and others in her research identify that societies, whether they're in state by state in the U.S., whether they're counties or between nations, those locations that have more primary care, physicians to help the population, they enjoy better health status of their people, they have better clinical outcomes, and they have lower cost. So building primary care is fundamental to healthcare reform in the country, and linking it tightly with an accountable care organization that again becomes responsible for a triple aim for the population of patients entrusted to them. I'd suggest to you that's the foundation for health system reform for the country. Thank you.
Thank you, panelists. I want to tie a couple themes together that the panelists raised, and then we're going to open it for questions. We'll have about, I think, 20 minutes or so for questions. So the panelists, I think you heard some really interesting perspectives. You heard some optimism, and I actually want to say, Vondi and David, in your presentations, you really gave a sense of optimism, because what you're talking about are local innovations, and I agree with both of you that there's been some incredibly creative work done on the ground in communities in all across the state, all across the country, in terms of finding ways to improve access, quality, to take responsibility for populations, even in the absence of anything happening at the federal level. So I think those are really good things to keep in mind if you want to look for beacons of hope for the future. Now, you heard from Mark and from Steve some real challenges in terms of the difference between access to care and insurance. And I think the points that they made are truly important to keep in mind. The legislation and much of the language around the legislation that's been talked about in Congress really did focus on having insurance reform. And Dennis told you why that's really important, and really talked about that as a value. But I think you also heard from this panel that insurance reform certainly is not enough. And there's no question that if we look at Medicaid, we know, and I can speak to this as former director of the Department of Human Services, all of our foster kids had Medicaid coverage, and we could not get dental care for most of those kids because there are so few dentists in the state that would take Medicaid coverage, and it's only getting worse with our budget crises. So there is a huge difference between access to care and insurance coverage. And that's something the legislation is Mark said, was in fact in some ways going to exacerbate. You know, we really didn't have a solution to that problem in the bill. And then I want to come back to Dennis's point, because I think we also have to keep this in mind. Dennis said that the status quo is not acceptable, and something's going to have to change. And I did notice when he was cheering for the baby boomers, this whole section of the audience was looking like, who? You know, this is there is another generation here as well. But it is the case that the baby boomers are indeed going to tax the system, and unfortunately, those of you entering the workforce are going to end up paying one way or the other for the baby boomers, because you'll be working when the baby boomers are retired, and that is how the system works in its current structure. And so Dennis's point is well taken, that something is going to have to change. And right now, we have no social philosophy like every European country does on healthcare. I mean, every European country, the reason that we are the only country in the developed world that has no form of universal coverage, and you may have heard this last night, I don't know if they mentioned this, is because they believe that health care, and they mean it in the broader sense than health insurance. They believe that health care is a fundamental part of the social compact in society. We have no social philosophy at all. You know, we're very mixed in our view that it all should be in the market, it all should be, or there should be some social responsibility, and we have policies at the federal level that go both ways. And it is, again, part of the challenge of getting something at the federal level that speaks to health reform. Dennis is right, the status quo is not an option. The question is, what will change if we can't come to some view of what, you know, and David said, what should the organizing principle of healthcare reform be? Everybody cheered when VONDIE said we need to just do it, but what is it? We don't all agree. And we saw that Congress came awfully close and, wow, backed way back. And there really are fundamental issues to address here. When healthcare reform failed in the Clinton administration, 94, I think a lot of people in this country at that time thought, great, the status quo, I'm more comfortable with the status quo than I am with these, with what was proposed in that legislation, and so that's what we're going to have. Things will just go on as they did. But if you lived through that period and were, in fact, insured by an employer, you know that's not what happened. In fact, what happened after healthcare reform at the federal level failed is all of the employers in the country said, well, we can't continue, and then we were seeing rates of increase in healthcare spending at 12% or more. We can't continue with those kinds of rates of increase. And so we've got to do something. And wholesale, within 6 months, just about every employer dropped their old traditional commercial insurance and went to managed care, went to HMO forms of care. And lo and behold, healthcare spending moderated pretty dramatically for 3 years, and people hated it. Hated it. And then we started getting all this managed care backlash legislation, very ill-conceived, very poorly done, very reactive to public opinion. Status quo will not be maintained. Dennis is right. It cannot. So what will be put in its place, and how do we get there? Local models are great, but they're not going to be the only thing that happens. So with that, I think we're open for questions for the panel, and you are first. Could you introduce yourself and just say a word about where you're from?
My name is John Cavese. I'm a family physician here. Actually work with Dave for Advantage Health, and I actually was going to quote T.R. Reid as well as Steve did, only I saw him at the January series. I haven't read his book. I've seen the movie. And one of the points that he made that is very striking to me is that you're right, what you just said. We as a country haven't made the moral decision like the other countries that treating all of your citizens is the right thing to do. As physicians, I believe that's something that we have not taken the reins of and helped to make people make that decision. What you said about what the people want, actually more than 60% of the population actually want a system where everybody's covered under a government-funded system. What you said about Medicare and Medicaid, Mark, was misleading, I think, in that if it wasn't for the fact that the private insurance companies dumped their sick patients on Medicare and Medicaid, they wouldn't be in as financial straits as they are. So my questions are, one, what can we do to convince the profession of medicine to make a moral stand and say what is right to get everybody covered? And two, why in this discussion to formulate health care, we have allowed insurance companies and pharmaceutical companies to be part of the discussion when they are the ones that benefit most with the status quo and maintaining things the way they are.
Provocative. Go ahead. We'll go down the panel.
I wanted to clarify too. Medicaid and Medicare are programs in which you must receive eligibility. Medicare is obviously for senior citizens. Medicaid is income-based. It has nothing to do with private insurance dumping you and therefore finding your way into that. I want to underscore the themes, and first of all, just point out, if any of you know me, I am an incurable optimist. So certainly I, too, am very hopeful that we will be able to change the system that we have today. But coverage does not equal access. And that's a theme I really want to make sure that everybody understands. What I was trying to lay out with regards to the underfunding of Medicaid and Medicare is that our fear is that a third, likely underfunded government-run program is not the solution. We need to have a competitive health insurance marketplace where individuals, families, businesses can buy the insurance coverage that they need for themselves, for their employees, for their families, and the like. I also agree that we do need to find an agreement as a society with what is a minimum benefit of care we wish to provide individuals, and then pay for it. Pay the providers so that they can pay their employees, keep the lights on in their building, buy the equipment that's necessary. Everybody wants those things when it comes to the care that we receive, but if you're not paying providers, you're not paying hospitals, technology and access is going to suffer as a result, and therefore the quality of care is going to be significantly limited.
Then, Vondie, you want to comment too?
Yeah, I feel sorry for doctors. I really do, because one of the fastest growing models in the United States today is a program called Project Access. You have one here in Grand Rapids where physicians have very quietly agreed to take uninsured people and integrate them into their practices and help them. And the reality is that if we can't figure something out, that's only going to increase. And there's just so many of those slots and so much ability that physicians have to take on that additional load, as well as then, funnel those folks into specialty care where they need it, and then work out a free operation if they need that. I do think that there's a moral piece that comes into this. We talked about it a little bit last night, and it was somewhat, in a way, it got a little flippant at points. I can't help but believe, from a very human basis, that if there but for the grace of God go I may have the best coverage in the country, and if I lose my job, it is gone, and I am with everybody else. We had a young man come in right after the economy kind of fell apart, back in 2008. 28 years old. He'd lost his job in the morning. Physician called us in the afternoon. He'd just been diagnosed with an advanced form of lung cancer. Now, for the physicians who are continuing to take those folks in their practices who suddenly are dealing not just with the crisis of medicine, but the crisis of economic problems for people, that's untenable. And maybe the first step is some agreement that we all agree that everybody ought to have minimally the ability to get health care. And once we make that decision, then what does that health care look like? We don't compete for the uninsured. You can create the best competitive package anywhere, but That's for people who can afford to pay the bill. If you can't pay the bill, then these folks fall out, and they fall out into those practices, and the physician is left carrying that burden. I do agree. Maybe that's the one thing we haven't done, is had that moral argument or the moral statement that, you know, besides life, liberty, the pursuit of happiness, and the ability to carry a gun, that, oh my gosh, if I'm sick, I can go to the doctor. What is so hard about that?
Dennis, do you want to comment?
Following up on that, Ian Morrison, a popular healthcare futurist from Canada, identifies Canadians as, you recognize Canadians, we're the ones with health insurance but without the guns. Decisions you make, I guess. To the doctor's point, 2 questions. What can we do to get providers to step forward? And I would have to say I am very proud of the primary care community for coming together, trying to do the right thing, transform primary care, at the same time working with the payers to try to get the payers to recognize that we need to transform primary care. The limiting factor is it's a zero-sum game, and if you're a physician but not a primary care provider, you're not sure this is a good idea. So medicine, the House of Medicine has its own internal fights that it needs to resolve. And it will resolve them because you don't have a choice. Your second question, why do we have insurance companies and pharmaceutical companies at the table? Because they got money. Yeah, those are the, and we seem to love insurance companies. We don't seem to be real concerned that we're running our healthcare delivery system off the table as long as the insurance companies are stable. We need to make sure the banks are stable. We need to make sure the auto companies are stable. We seem to focus on the big money players. And I won't speculate as to why.
They pay the bills.
Oh yeah, that.
Better lobby.
Well, it's, Mark said he was a optimist. I'm a glass empty, half empty kind of guy. My students don't call me Mr. Sunshine for nothing. So, and I'm going to, I usually try not to repeat anything I haven't read, but I thought, and to your point, which I thought was really interesting, and I was in the car one morning and I was listening to the Diane Rehm show, and she was talking about the health bill, and again, sort of back to the F's, is that, perhaps the answer's there, we just can't see it, right? Which is sort of what my point was with giving you that little exercise this morning. And that perhaps we need to change our paradigm. But back to the Canadian model, do you know how many pages the Canadian bill was? Yeah, it was three or four pages, Lodi? Thanks. Yeah, I heard it was 3 or 4 pages. So how did we end up with a 2,000-page bill that didn't cover everyone, right? They had a 4-page bill that covered everyone. Very interesting, right? It's a paradigm shift. It's about covering everyone. And again, we think we have to abide by all these special interests and take care of this and that and exempt this and that. But I thought that was fascinating to hear that. Why does it have to be that complex? I don't know, right? We sort of sit here and says it has to be that complex. Maybe it doesn't. Maybe we reach the point to where we do need a 3 or 4 page bill. Again, how do you get behind a 2,000-page bill that no one's read, no one understands, and right, we all fear the unknown. But maybe if we had a 3 or 4 page, maybe a 10-page bill, right? Let's go for the moon here. Maybe that's something that most of America could read and understand. Perhaps I'm being naive and overly simplistic here, but anyway, I thought that was a really interesting contrast between United States reform and Canada's reform.
David?
I think support for the notion of universal access is certainly growing, and it's going to grow, I think, both because we as a society recognize a moral obligation, and secondly, actually there's going to become more people without insurance if we don't step up to it. In fact, as we heard from the speakers yesterday, you can see the corporate-sponsored health care becoming a bigger and bigger burden, and it's increasingly likely that the number of people without insurance will grow and may grow dramatically, as we've seen in even some of the counties in Michigan. So it will be a larger and larger constituency that will say we've got to have another way to fund health care insurance. I think there's even a place that one ought to consider. There's a social contract that we have with each other in a society. We have an extremely diverse society, and actually you have to have ways that people think that they still have ways that they relate to each other and belong to the same larger community. And I think that healthcare actually is one of those things that helps to bind the society together. Now what we have to figure out is what are we actually going to pay for, and that's really, I think, that's where the biggest struggle is, and I think that's a big conversation both within medicine but then also a larger level in society. How do we figure out to cover everybody, but we're not going to do everything? I mean, pretty soon we're going to be able to design everybody their own organs. Once you figure out how you can do it and do it safely, does it become a covered benefit? I mean, there is no end to where this is going. So I think we're going to need some level of universal coverage, but I think it might be a more basic level of coverage, and that could be affordable.
Thank you.
The preceding program is copyrighted by Grand Valley State University. Visit us at gvsu.edu.